Hello my dear subscriber and viewers, welcome back to Akshara Akshita 2023 channel. In this video, I am going to explain about respiratory coding guidelines part 1. So in third series, I am going to post separately for CAPG, pacemaker and all other minor procedures. So the first part will be respiratory coding guidelines. So in last video, I have completed intercommentary series separately and musculoskeletal modifiers, then basic surgery coding guidelines and CPT introductions. So those who are not watched those videos, please check my playlist. So I have posted in English and Tamil also. So and please, before going to this video, please subscribe my channel. And let's start from the respiratory coding guidelines. The first coding guidelines will be biopsy. So whenever doctor is performing biopsy, so along with that more extensive procedure, so biopsy cannot be coded with the more extensive procedure. If the biopsy performed prior to the extensive procedure and decision made to perform the extensive procedure, then we can bill both procedures separately with appropriate modifier. For an example, patient came with nostril obstruction and performed biopsy. So along with that nostril polypectomy. So in this section, so polypectomy is an extensive procedure. So with that extensive procedure, biopsy cannot be reported. So both are same site. So biopsy cannot be reported with the more extensive procedure. So now the 31237 shall not be reported with 31255. 31255 is a removal of polyp from the endoscopy from the nostril by endoscopy method. Okay. Next coding guidelines is diagnostic versus surgical endoscopy. So always surgical endoscopy includes diagnostic endoscopy. So diagnostic endoscopy and surgical endoscopy cannot be coded together. So this guidelines is applicable for all of the chapters. Whenever diagnostic and surgical, so diagnostic always included into the surgical endoscopy. Okay. Because before going to do the surgical endoscopy, doctor may perform diagnostic endoscopy to access the surgical site. For those reason we cannot code diagnostic endoscopy separately with the surgical endoscopy. So after complete the procedure and again doctor may do the diagnostic endoscopy to check the any intraoperative injuries or any bleeding. So for that also we cannot report diagnostic endoscopy separately. If medically reasonable and necessary endoscopy procedure are performed with two regions of the respiratory system with two different types of endoscopy, then both procedure we can bill separately. So two different region, two different type of endoscopy, then we can code two endoscopy separately with appropriate modifier. For an example, if the patient requires diagnostic bronchoscopy for lung mass with fibrotic bronchoscopy and separate laryngoscopy for laryngeal mass, then the same patient, then we can code both separately, because for both surgeries we have separate medical reason to do the procedure. So both the codes we can code together. For an example for diagnostic versus surgical endoscopy, if the endoscopy anterior ethmoidectomy is performed and diagnostic nozzle endoscopy also performing. So nozzle endoscopy and ethmoid both are same site. So when doing ethmoidectomy only, doctor is performing diagnostic nozzle endoscopy. So that time diagnostic endoscopy we cannot be coded with the ethmoidectomy code. Okay. So as I explained to you in each chapter, so diagnostic scopy we can bill it with a more extensive procedure when if same day itself patient is coming for any bronchoscopy, diagnostic bronchoscopy, and for lung mass with that bronchoscopy, and doctor is deciding to do procedure same day itself. So if medically reasonable or necessary endoscopy performed same day and it leads to the decision for the surgery, then we can code diagnostic endoscopy separately. Then this point also I have already explained to you. If the diagnostic endoscopy or any bronchoscopy procedure to access the surgical site or to evaluate any intraoperative injury occur, do not report diagnostic endoscopy separately. Okay. The next guidelines is endoscopy converted to the open procedure. So this guidelines also it's the same as per the basic coding guidelines. If the diagnostic procedure fails and it's converted into the open procedure, then endoscopy procedure is not separately reportable with open procedure. So the same point I'm explaining each chapter. So for all chapter I'm going to explain this, because this is the initial guidelines before starting the each chapter. So whenever in one procedure started and it's failed to open method, just in what method doctor is completing the procedure, that method only we have to code as a final CPT code. Okay. So next guidelines is exploration with the more extensive procedure. So always exploration is included into the major procedure, like more extensive procedure. So surgical sinus endoscopy includes cyanotomy and diagnostic endoscopy. So if the medically necessary procedure is cyanotomy and sinus endoscopy is performed, then we can code both codes separately with the appropriate NCCE modifier. Okay, so with that cyanotomy or any diagnostic endoscopy, so both is included in the surgical sinus endoscopy. Okay, so as I told you, explained already, so always this exploration and this diagnostic doctor may do to access the surgical site. So then it is for those reasons we cannot code that's either cyanotomy or diagnostic endoscopy. We cannot bill with the more extensive procedure. Okay, then next coding guidelines is control of bleeding with extensive procedure. So control of bleeding is integral component of endoscopy procedure and it is not separately reportable. For example, control of nasal hemorrhage, CPT code is 30901, is not separately reportable for control of bleeding due to nasal or sinus endoscopy procedure. So due to that procedure, so control of bleeding, so in that main procedure, control of bleeding doctor is performing, so end of the procedure, then it is an integral part of the more extensive procedures. So sometimes we can bill it control of bleeding. So when we can bill control of bleeding procedure, so if the bleeding occurs in post-operative period and it is records returned to the operative room again, and treatment also doctor is performing for control of bleeding, then we can bill it control of bleeding CPT code with the 78 global period modifier 78, that is complication after the procedure complication, the bleeding is a complication, so post-operative modifier 78 we can bill it. The following procedures cannot be reported with the nasal endoscopy or other sinus procedure or more extensive procedure. What are those procedures? Ablation or inferior, any major procedure like 30901, 30801, 30903, control of hemorrhage or anterior, 30905, control of hemorrhage posterior, 31238, nasal or sinus endoscopy surgical with the control of nasal hemorrhage. So these following procedures cannot be reported with the main extensive procedure. These are the bleeding procedure, control of bleeding procedure from the respiratory system. So those procedures we cannot bill with the major nasal endoscopy or any nasal related more extensive procedure. We cannot bill with these following CPT codes. Okay, so only one reason we can bill the control of bleeding procedure, so that if the bleeding occurs in the post-operative period, then we can bill that CPT code with the 78 modifier. Okay, then next point is multiple procedure. If the multiple services were performed and are not adequately described by single CPT, so if we don't have any combination code for the multiple services, then we can code all services separately with the 51 modifier. Okay, So in this section, actually incidental examination of other areas shall not be reported separately. So whenever if multiple procedure are performing, for those multiple procedure, if we don't have any single CPT like a combination CPT, then that all services we can code it separately with the appropriate modifier, that is 51 modifier. So with the second service CPT codes, okay, additionally only medically necessary services may be reported, only medically necessary. So incidental examination of other areas shall not be reported separately. Then let's see what are all the inclusive procedures in this sections. There are so many are there. What are the inclusive procedures? Which codes we cannot code with the which code? So let's see one by one. Please check CPT code 31292 to 31294 cannot be reported with the following procedures when performed on the ipsilateral side. So if it is ipsilateral side, the following CPT we cannot bill together with the 31292 to 31294. The first code is 31256, that is maxillary osteotomy. Second code is 31267, maxillary osteotomy with removal of tissue. Then 31276 frontal, 31282 sphenoid, 31288 sphenoidectomy with removal of tissue. So those set of CPT codes we cannot bill with the code range from 31292 to 31294 if it is on the ipsilateral side. If the contralateral side, then we can code both codes separately with appropriate modifier. If it is ipsilateral side, then this following CPT codes we cannot bill with the above CPT codes. Okay. Then next point, CPT code 3010130 is also included and cannot report separately with the more extensive procedure if it is ipsilateral side. And to allow the because this procedure doctor may do to allow the access to the ethmoid or other sinus to perform those procedures, then we cannot bill with it 31292 to 31294. But however, this CPT 30130 may be reported separately if performed on ipsilateral side for purpose of unrelated to the allowing access to the sinus to perform the procedure. Then we can bill it with the 31292 to 31294. Exception this 30130 we can bill it only for one reason. So this procedure should perform purpose of unrelated to the allowing access to the sinus. Then we can bill it 31292 to 31294. Then next point is, if any of the included procedures are performed on the contralateral, as I told you, contralateral side, then we can bill both the CPT code. Okay. The next point is, flexible laryngoscopy and direct laryngoscopy shall not be reported for same patient. Okay. Then 31000 31002 lavage by cannulation of respiratory accessory sinus is an integral component when performed with the more extensive procedure. Okay, if the procedure performed on the ipsilateral side, then in the same patient we cannot bill together. If the laryngoscopy is required for elective or emergency placement of endotracheal tube, and laryngoscopy is not separately reportable. Okay, sometimes doctor may do the placement of endotracheal tube. To keep that endotracheal tube, doctor may do the laryngoscopy to access the site. So for that reason also, laryngoscopy we cannot bill with the endotracheal tube. Okay. Then next point is, CPT code 31500 describes an emergency endotracheal intubation CPT code. this CPT code we cannot bill with the bill when an elective intubation. So this CPT only emergency intubation. If when doctor is performing for elective intubation, then we cannot bill this CPT for elective reason. Okay. Then next point is 31600 tracheostomy planned procedure. So this CPT code description itself separates procedure. So this separate procedure you know already, as I told you in basic coding guidelines itself, always separate procedures. We cannot bill with the any other CPT code. Okay, so if it is unrelated site, then we can bill it, but related to same site, if separate procedure description CPT code cannot be billed with the main procedure. Like same point here also will applicable. So 31600 is tracheotomy planned separate procedure, so cannot be billed with the main procedure. Okay, then next point is laryngoscopy. Laryngoscopy is not separately reportable when it is required for placement of tracheostomy. So as I told you already, so tracheostomy CPT code ranged from 31600 to 31610. So laryngoscopy we cannot bill with the placement of tracheostomy. Then next point, CPT code 92511. Nasopharyngoscopy with endoscopy separate procedure. So this CPT code also separates procedure, shall not be reported separately when performed as cursory examination with other more extensive procedure. Okay. So these points also you know already. This also separate procedure. We cannot bill with the main procedure. Then next point is diagnostic thoracoscopy. CPT code is 32601, 32604, 32606. These codes cannot be reported with the surgical endoscopy on the ipsilateral side of the thorax. If it is contralateral side surgical and diagnostic thoracoscopy, then we can bill it. If it is ipsilateral side of the thorax, we cannot bill diagnostic thoracoscopy with the surgical thoracoscopy. Then next point, diagnostic thoracoscopy to access the surgical site or to extend this disease before doing the open thoracotomy or thoracostomy or mediastinal procedure, then we cannot bill separately with the main procedure. Okay, this is also old point only. Then next point is CPT code 92502. Otolaryngological examination under the general anesthesia. So this CPT code also we cannot bill with the more extensive procedure of otolaryngologic CPT codes under the general anesthesia. Okay. Then next point is diagnostic thoracoscopy is separately reportable with the open thoracotomy or thoracostomy or mediastinal procedure if thus findings of diagnostic thoracoscopy leads to decision to perform an open procedure in like thoracotomy or thoracostomy or mediastinal procedure, then we can bill diagnostic thoracoscopy with the main procedure with the 58 modifier. Okay, this also old point only, as I told you this before in each chapters. Okay, then next topic is thoracoscopy is converted to an open treatment. So this also same story only. If the surgical thoracoscopy is converted to an open thoracotomy, then surgical thoracoscopy is not separately reportable. Additionally, diagnostic thoracoscopy shall not be reportable with the surgical endoscopy procedure with open procedure. Okay. So what procedure with which method doctor is completing the procedure, so we should have to code that method only as a final CPT code. Okay, then thoracotomy with exploration, the code is 32100. This code also we cannot report with the open thoracic procedures because, as I told you already, exploration is always included in the main procedure. Okay, then thoracotomy can be reported with the following reasons. What all the reasons that exploration we can code it? So if it is performed on the contralateral side, or it is performed on ipsilateral side through the separate skin incision, then if it is performed and obtain the biopsy at a different site than other open procedure performed. So for these three reasons, we can build thoracotomy with the main procedure. The first reason is contralateral side. The second reason is ipsilateral side through the separate skin incision. Then third reason is to obtain the biopsy at the different site than other open thoracoscopy procedure. Okay. Then next point is tube thoracostomy 32551 CPT code. So may be performed for drainage of the abscess, emphysema or pneumothorax. For this reason, doctor may do tube thoracotomy procedure. Okay, so this code described for CPT 32551 definition as a separate procedure. So as per the coding guidelines, always separate procedure, we cannot bill with the main procedure. So if it is when it is contralateral, if it is ipsilateral, we cannot bill it. Okay. So if the another open procedure of the thorax, unless is performed in the thoracic cavity contralateral to one entered, performed to and one thoracoscopy, thoracic procedure, then we can bill it thoracotomy and main procedure separately. Okay, so whenever the CPT description says it is a separate procedure, please check whether main procedure and that separate procedure CPT code is ipsilateral or contralateral. Okay. Then next point is the following procedures cannot be billed with radiological examination. What are the radiological examination? 71045 and 71046. So these two codes we cannot bill with the following CPT: pleural drainage procedure and thoracentesis procedure, then chest tube insertion procedures. So the pleural drainage procedure is 32556, 32557. Thoracentesis procedure CPT codes are 32554 and 32555. Chest tube insertion procedure CPT codes are 32550, 32551. So these three procedures, when doctor is performing with a radiological examination, we cannot bill radiological examination with these procedures. Okay. Then next point is biopsy of lung versus more extensive procedures. This also same as previous point only. So both cannot be reported separately if the anatomical location is the same. If it is different anatomical location, then biopsy of lung procedure and more extensive procedure of the biopsy, more extensive procedure of the lung procedure, we can bill it together with appropriate modifier. Okay guys, that's all about from the respiratory coding guidelines. So if you have any doubt in any chapters which I explained to you already, please don't hesitate to comment, then I will reply you. Then thank you for watching this video. Those who are not subscribed my channel, please subscribe my channel and support my channel by clicking click. Okay. And thank you guys. Let's see in the next chapter CAPG. This is very important topic. Those who are going to write CPC exams, definitely each year, each exams, this question will come. Either one or two question definitely will come. So next video it's CAPG. Okay guys. Thank you for watching once again. Thank you for watching my video. Bye bye.